Folate deficiency as a contributor to migraines is an intriguing and surprisingly underdiscussed area in both nutritional science and neurology. While most people associate migraines with hormonal fluctuations, stress, dehydration, or even caffeine, few realize that a simple micronutrient imbalance, namely a deficiency in vitamin B9, might be setting the stage for recurring attacks. This connection is not just coincidental. It emerges from the biochemical landscape in which migraines originate, one where neurovascular sensitivity, inflammation, and genetic predisposition all play a part. Folate, through its unique role in methylation and homocysteine regulation, appears to sit at a critical intersection of these mechanisms. One of the most consistent biochemical findings in people who suffer from migraines, particularly those with aura, is elevated plasma homocysteine. Homocysteine is a sulfur-containing amino acid that, at high levels, becomes neurotoxic and vasculotoxic. It can impair endothelial function, increase oxidative stress, and disrupt blood-brain barrier integrity, all of which can lower the threshold for migraine initiation. Folate, along with vitamins B6 and B12, is essential for keeping homocysteine in check by converting it into methionine via the methylation cycle. When folate is lacking, this pathway slows down, leading to a gradual accumulation of homocysteine and, as many studies now suggest, a higher risk and severity of migraine attacks. Several clinical trials and observational studies have supported this link. In particular, people with genetic polymorphisms in the MTHFR gene, especially the C677T variant, appear to be at higher risk for migraines and have trouble metabolizing folic acid into its active form, 5-methyltetrahydrofolate, 5-MTHF. This reduced enzymatic activity impairs methylation and leads to elevated homocysteine, even with normal dietary folate intake. In these individuals, supplementation with bioavailable methylated folate, rather than synthetic folic acid, has shown promising results in reducing both migraine frequency and intensity. One randomized trial found that a combination of folate, B6, and B12 reduced migraine disability scores and plasma homocysteine in patients with the MTHFR mutation, reinforcing the idea that targeted nutritional intervention can modulate underlying biochemical risk factors. But folate's relevance to migraine does not end with homocysteine. Its role in neurotransmitter synthesis adds another layer of interest. Folate supports the synthesis of same acetylmethionine, a universal methyl donor involved in the production of dopamine, serotonin, and norepinephrine, neurochemicals deeply tied to mood regulation, pain perception, and neural excitability. Migraineurs often have imbalances in these neurotransmitters, particularly serotonin, which is thought to play a role in both triggering and resolving migraine episodes. If folate is deficient, methylation slows, neurotransmitter synthesis falters, and the central nervous system becomes more vulnerable to excitatory triggers. The result? A heightened likelihood of neurologic overreaction to what would otherwise be harmless stimuli, flashing lights, minor stress, sleep changes, leading to the cascade of vascular and neural events that define a migraine. Even the vascular component of migraine, which has traditionally focused on vasoconstriction followed by rebound vasodilation, is likely influenced by folate. Adequate folate supports nitric oxide metabolism and endothelial function, ensuring smoother blood flow and less inflammatory signaling in the brain's delicate vascular network. This is especially relevant in menstrual migraine, where estrogen-driven changes in cerebral blood flow can act as a powerful trigger. Women with subclinical folate deficiency may find that these natural hormonal shifts become exaggerated, not because of the hormones themselves, but because the body lacks the nutritional flexibility to modulate their vascular effects. There is also an emerging immunological perspective to consider. Folate deficiency is associated with increased systemic inflammation and altered immune signaling, both of which have been implicated in chronic migraine pathophysiology. Low folate may allow inflammatory cytokines to linger longer or reach higher concentrations, creating a pro-inflammatory state that primes the trigeminovascular system for activation. Over time, this can sensitize pain pathways and shorten the refractory period between attacks, making migraines more frequent and difficult to manage. What makes folate's role in migraine especially compelling is how silent the deficiency often is. Folate status is not routinely checked in migraine patients, and symptoms of deficiency, fatigue, irritability, poor concentration, can be mistaken for side effects of the migraines themselves. This makes it possible for folate deficiency to quietly perpetuate a migraine cycle without being recognized as a contributing factor. Add to this the fact that many common medications, such as birth control pills, antacids, and anticonvulsants, can deplete folate, and the potential for a hidden nutritional trigger becomes even more plausible. Addressing this doesn't require extreme measures. For most individuals, increasing dietary intake of natural folate from leafy greens, legumes, avocado, citrus fruits, and fortified grains may be sufficient. For those with MTHFR mutations or more persistent symptoms, supplementation with 5-MTHF and a full B complex may be necessary to see improvements. The key lies in individualized assessment, especially for those who experience migraines that seem resistant to traditional interventions or those who notice patterns linked to diet, stress, and hormone cycles. In this context, folate becomes more than a supportive nutrient. It becomes a modulator of neurological and vascular sensitivity, a buffer against inflammatory overload, and a gatekeeper for neurotransmitter balance. While it may not offer an instant cure for migraines, its absence creates a metabolic terrain that is far more prone to triggers and far less capable of recovery. Reintroducing folate into the discussion, nutritionally, clinically, and biochemically, may offer migraine sufferers not just a new treatment avenue, but a quieter, deeper sense of resilience.